Thank you again for your attention. I think we need to talk about bladders a little bit more again. I wanted to just review the management of overactive bladder because of some new treatment modalities. It's ever evolving, as with many fields in medicine. However, I wanted to touch on the medical management of overactive bladder in terms of pharmacotherapy, oral pharmacotherapy, and bladder therapies, Intradetrusor in injections. So I'll touch base on these, and hopefully some of these treatment modalities will be available. I understand that primarily tolterodine is being used in Kuwait. Is that correct? Hopefully we can talk about some other options. Again, perhaps there's a little bit more conflict here. However, I think there's enough representation that there's less conflict. Now, I want to, first of all, review and better understand the signs and symptoms of overactive bladder, review the various treatment options, and then we'll, like I mentioned, talk about neurotreatment modalities. Now, what's the definition of overactive bladder? It is urgency with or without urgency incontinence, usually with frequency and nocturia. So typically we're talking about OAB wet in patients within the field of urogynecology. I'll skip over this part. The key questions, though, to ask patients when you're taking a proper history, of course, are how much is the urgency and nocturia affecting quality of life? Because this is the big issue. The prevalence of overactive bladder is significant from a male and female standpoint, and it certainly increases with age. Now, normal bladder should be filling without any concomitant detrusor contraction. There should be no resistance to the filling. However, an overactive bladder will contract involuntarily, resulting in patients getting the sudden urge to void at a socially inappropriate time. Now, this is very important. I always refer to this in terms of the impact on quality of life, because certainly no one is going to succumb to an overactive bladder. However, it will impact all aspects of their life, be it their work life, their home life, their social ability to socialize. This can impair patients from even leaving the house. The classic situation is here, I guess the example would be at the avenues. Patients, if they are able to get out, will know exactly where every bathroom is located and strategize their shopping to allow them easy access to the bathrooms. This will impact their relationship with their friends, because a lot of times, as with fecal incontinence, there is the stigma of urinary incontinence, and patients will not speak openly about this, even with their close family or friends. It will impact their relationship with their partners, because certainly there is a body image kind of issue that is associated with constant leaking of urine, use of pads, chronic soiling of undergarments, and certainly something to ask patients about. Ask the open-ended questions. How is this impacting your life? And allow them to elaborate on this. Quick patient awareness tool is the OAB V8 that, again, my patients tend to wait in the waiting room, so I do equip them with something to do while they're waiting, and this is an easy way of screening patients for whether or not overactive bladder is significant. I will re-emphasize this. Behavioral and lifestyle approaches are so important. Retraining the bladder is very important. asking patients to keep a bladder diary for 2 or 3 days leading into the visit, or equip them with a bladder diary. Just ask them to document what they're drinking, when they're voiding, how much they're voiding, how much they're drinking, and evaluating. I had a patient who was a truck driver, and she was going to the bathroom all the time, had to make multiple stops, was impacting her ability to provide, it was impacting her employability, basically, in that she was voiding all the time, and the shipments weren't arriving on time. And I asked her, so keep this diary for me, what are you drinking? And it was coffee and coffee and coffee and coffee. And by the end of the day, she was consuming well over 1.5 liters of coffee, which certainly from a caffeine intake standpoint may be necessary in her role of employment, and ours perhaps as well, but something that can be managed ahead of time. Certainly, the other question that needs to be asked is, what type of products are patients using? The easy thing for a patient to do is to go to the pharmacy and purchase menstrual pads. And menstrual pads certainly are counterproductive in my incontinence patients because they do not work very well in terms of absorbing urine. Invariably, these patients I share with my vulvar clinic colleagues because they have significant irritation from using the wrong sanitary pads for the problem at hand. There is a stigma certainly in buying incontinence pads because of the worry of being exposed. And certainly, I think we need to be more open with our patients and ask the appropriate questions so that we can direct them better in terms of managing this embarrassing situation. This is a quick little study that was done, just emphasizing the fact that combined therapy is important. So drugs alone can work, but drugs with behavioral therapy, physiotherapy work a whole lot better. So there are many medications out there and treatment options for overactive bladder, and as one falls by the wayside, a new one seems to become available, and it's always the next and greatest thing. I just wanted to touch on treatments with anticholinergics and treatments with beta-3 agonists. Now, the distribution of receptors in the bladder are such that the detrusor muscle primarily has cholinergic supply in terms of M2 and M3 receptors, and there are beta receptors as well. And this kind of just is an illustration that demonstrates what an anticholinergic will do. They will prevent contraction of the detrusor muscle, and a beta-3 agonist will promote relaxation of the bladder muscle. So inherently, they have a similar outcome, but they do have a different approach in terms of managing the symptoms of overactive bladder. So this is the list of medications that I have access to. I know the list may be a little bit shortened here in Kuwait, but certainly there are two major families, the anticholinergics and the beta-3 agonists. Tricyclic antidepressants may play a role given that there are anticholinergic properties, and certainly can play a role in some patients that have mild stress urinary incontinence where the data isn't terribly conclusive, but there may be potential improvement in terms of those patients with mild mixed incontinence. Now, what are the side effects of anticholinergics? We all know these. Dry mouth constipation are the main ones that patients will not tolerate and probably stop taking their medications based on these symptoms. However, the ones that I find the most concerning are the cognitive effects. The cognitive effects, especially in an elderly patient population, as the incidence of overactive bladder increases in these patients, we're more likely to affect patients that may already have a baseline cognitive dysfunction but exacerbate things significantly better. The question is the permeability of different molecules. Ditropan is always, or oxybutynin is always vilified because of the fact that it's highly lipophilic. It's a small molecular structure that easily permeates through the blood-brain barrier, resulting in more cognitive effects. Tolterodine is a bulkier molecule. There's lower lipophilicity, and certainly there's less permeability. The best medication out there is trospium chloride, which I do use in my patients that have baseline cognitive dysfunction because it's the only quaternary amine. It's a large molecule that does not cross the blood-brain barrier. So this kind of just illustrates the best and the worst. At the end of the day, though, like I said, overactive bladder is not going to cause patients, increase their risk of mortality directly. However, studies have shown that patients that are up at night, significant nocturia, urgency, are much more prone to falling and fracturing their hips. And certainly, there is an indirect pathway towards an impact on mortality, so certainly something to keep in mind. Fesoterodine. So fesoterodine is one of the newer anticholinergics called Toviaz back home. Again, it's a once daily dosage. It comes in 2 dosages. It is the safety and tolerability has been demonstrated in several studies, RCTs, blinded RCTs. The key thing with fesoterodine is that it's extensively converted to its active metabolite, 5-hydroxymethyltolterodine, which is much more specific in terms of its actions on the bladder versus tolterodine itself, where there's partial conversion to the 5-HMT. Tolterodine itself has a very variable effect on the bladder, and certain patients may respond very well, others will not. There's more of a homogeneous effect when providing patients with the 4 milligram or 8 milligram dose of the fesoterodine. Overall, there don't seem to be any differences when it comes to gender or age. There's no food effect. It's dosed once daily. There's no peaks and troughs in terms of its bioavailability. The timing of administration does not matter. I know with some of the more immediate release medications, that first 4-hour window is the best. This you can dose in the morning or in the evening without any issues. There's no QT prolongation, and it, as I mentioned earlier, there's less permeability, resulting in less cognitive effects. Satisfaction rate is quite high in these patients and seems to last long term, and this results in better compliance of this anticholinergic on patients. I've kind of summarized most of this. So mirabegron or Myrbetriq is the beta-3 agonist that I have available. It's one of our newer drugs as well. It has a slightly different mechanism of action. It promotes relaxation of the detrusor muscle, and it is quite effective. The question always is how we all know about the different beta receptors in the body, and the concern is always for the heart and the lungs. However, when we're looking at specificity in terms of the beta-3 agonist itself, it is quite specific to the bladder, and the side effect profile from a cardiac and a respiratory standpoint is not a concern. The main contraindication for beta-3 agonists is uncontrolled hypertension. although there is minimal effect on cardiac function, it is very important to take a baseline blood pressure, and upon review, once the patient has started the medication, your follow-up at 6 weeks, 3 months, whatever your interval is, to repeat the blood pressure to make sure that there has been no significant change. Pregnant patients shouldn't be taking this as well. There are two dosages, the 25 and 50 milligram dose. It's dosed once daily. Again, it has a very consistent effect over 24 hours. It can be dosed in the morning or in the evening. There are no peaks and troughs. And the efficacy has been comparable to other anticholinergics such as tolterodine, the long-acting, and certainly well tolerated by patients. I'm going to skip ahead to some other treatment modalities that are available and may be available here as well. Sacral nerve stimulation is an implant of an electrical stimulator. It's programmable. It's placed subcutaneously. It delivers low amplitude electrical stimulation via a lead at the S3 level. Typically, this is treatment that is used in patients that are refractory to oral anticholinergic or beta-3 agonist treatments. A temporary electrode is tested with an external pulse generator for 1 to 2 weeks, and if patients' symptoms do improve by 50% or more, then the consideration for a permanent electrode can be considered. It is quite effective in most studies and certainly has long-term effects in terms of those patients that will respond long-term. Another option, which is less invasive, is percutaneous tibial nerve stimulation. And again, this is less invasive than the sacral nerve stimulation. A fine needle electrode is inserted into the lower inner aspect of the leg, slightly cephalad of the medial malleolus, and again, an external pulse generator delivers an adjustable electrical stimulus. And usually the treatments are
2 minutes?
For 30 minutes.
Not 30 minutes?
For 12 weeks, followed by maintenance every 3 weeks, and this could be a viable option. I do want to touch, so there is lots in the literature that has proven the efficacy of the tibial nerve stimulation. However, I wanted to touch quickly on Intradetrusor Botox therapy, which kind of is the newest kid on the block in terms of treatment of refractory overactive bladder. Typically, the amount that I use is 100 units in patients with overactive bladder. In neurogenic bladders, you're looking at higher doses. It's administered either with a rigid or flexible cystoscope. Can be done in an operating room setting or in a cystoscopy suite setting. Typically, the patient will need either a mild sedation or will need retrograde filling with local anesthetic solution that's left in place for about 20 minutes, and it's quite well tolerated by patients. Essentially, you're looking at a 10 milliliter volume when you dilute or you reconstitute the Botox powder, essentially, and you're injecting half a milliliter into 20 locations. I usually divide the bladder into 4 quadrants and do 5 injections. You want to maintain injections into the dome of the bladder. Various studies have looked at if you inject it in one spot or spread it out, it seems to be quite efficacious in any case. And this is a study that just, again, it's 12-week data. However, there is longer-term data that seems to show that the effects last between 6 and 12 months. And there is significant reduction in episodes or incidents of urgency incontinence on a daily basis. We'll skip over that. The main take-home message is when you're evaluating patients with overactive bladder, ask about quality of life issues. Talk about bladder management, from managing fluid intake, managing caffeine intake, managing pelvic floor health with the help of our pelvic floor physiotherapists, and then the consideration of oral anticholinergics or beta-3 agonists should be your first-line modality when it comes to medication. Keep track of cognitive effects, especially when we're talking about our anticholinergics. The one advantage, certainly, with our beta-3 agonists is that there are no cognitive effects, and certainly in our more compromised patient population, this may be a first-line treatment from a medical management standpoint. And then once, if we establish after trialing certain medications that patients are not responding to the medication, the consideration of neuromodulation or intravesical Botox injections should be considered. Thanks again for your attention.